Good afternoon, everybody, and thank you for being here today and attending the lecture. Title of my presentation today is A Look Beyond the Epidermis, Capturing Microvascular Oxygenation with SnapshotNIR Infrared. Again, my name is Dr. Brian Lepow. I'm assistant professor at the Division of Vascular Surgery at Baylor College of Medicine in Houston, Texas. Thank you to the Desert Foot Committee for inviting me to give this talk, and to Kent Imaging for helping to sponsor this event. So wound and oxygenation overview. Let's talk a little bit about what it is that we're going to discuss and why these types of things are important. We know that wounds heal at a quicker rate when there is good blood flow or adequate oxygen available to the wound site and surrounding tissues. Wound is considered chronic once it fails to heal within a predictable healing time frame, usually about 4 weeks. Once it hits that 4-week mark, a wound does turn into a chronic wound. Failure of wounds healing may result in subsequently amputation of the limb, which are things that we're trying to prevent. Chronic wounds can lead to disability, and results are very poor with wound outcomes. The results kind of turn into a cycle of negative care for the patient, having a wound, non-healing, leading to amputation, subsequent disability. And we know those mortality rates for amputations are quite high, exceeding 50% in 5 years. And currently, oxygenation perfusion is tested with SPP or other modalities. Some of those modalities, unfortunately, are time-consuming, outdated with our advanced disease processes in this patient population. And although with the new Kent Snapshot device, the hope is that these technologies and the evaluation of the tissue perfusion can be improved, and that we can look to cut down on time for producing those images. And again, you can produce this instantaneous image, which we'll discuss further in the lecture. So we'll get into tissue assessment technologies. There's been variable technologies that have been out there. Some are intravascular related, and some are in forms of sort of a handheld type device. We know the hemoglobin has a distinct light absorbing characteristic in the visible and near infrared spectrum. Oxyhemoglobin and deoxyhemoglobin both absorb light differently. So this is why we're looking at 2 different types, and in this particular case, 5 different types of values here when we're taking these images. Measuring the reflected and absorbed light from the tissue and knowing how hemoglobin and oxygenated hemoglobin absorb light in those wavelengths allow for us to determine a relative portion of oxygen carrying hemoglobin. You can see here by these cool graphs, it kind of just distributes and disseminates and shows how and on the scale of where things are, from visible light on the left-hand side to the ICG-based fluorescence technologies to the snapshot, and what depths of tissues we're looking at. And then again, hemoglobin, as we discussed, does absorb light differently, and if it's carrying oxygen or not. Again, this is sort of just further defining different wavelengths that penetrate different depths. You can see the blue light versus the red light versus near infrared. And near infrared comes down all the way down to the subcutaneous tissue, allowing for much deeper penetration and evaluation, and things, again, that we really can't necessarily see with the naked eye. So near infrared spectroscopy measures hemoglobin oxygenated at the tissue and cellular surface, otherwise known as STO2. There are a lot of different terms we'll discuss today. We'll try to break those down for you. What near infrared spectroscopy provides is a non-invasive measurement of the content of oxygen bound to hemoglobin in the blood just below the surface of the tissue being imaged. It's measures of the capillary bed where exchange of oxygen occurs. So you can see in this diagram on the left, this is the snapshot device by Kent Imaging. And this is sort of a typical image that one would see. And on the right, just showing and demonstrating the SaO2, the arterial oxidation, the STO2, at the tissue level, and the SVO2 at the venous level. And this just really kind of gives a glimpse as to the different images that are captured by Snapshot. Snapshot captures 5 particular images. On the left-hand side, you have a demonstration of an individual's hand with a tourniquet over the finger. And that's your color and or RGB view. And this is all provided to you when you obtain an image using this type of device. We move over to the right-hand side. At this top image here, you have the STO2. And again, you can see where the tourniquet's placed. You're seeing some decrease of oxygenation at the tissue level. And you can see that as the rest of the hand is that red color or oxygenation is positive there, where you have a decreasing oxygenation at the finger where the tourniquet is. Going down from that slide, you have your total hemoglobin, and then moving over to your deoxygenated hemoglobin on the top right slide. And on the bottom, you have your oxygenated hemoglobin below that. And you can see all the differentiated effects by the use of that tourniquet and how that blue color is differentiating the oxygenated hemoglobin versus the rest of the fingers have oxygenation to them. So this is the kind of a classic view of what you'll see, and you can toggle back and forth when using your device to be able to look at these different imaging states. So I know this slide's quite busy, and we'll kind of go through it a bit, but sort of, a lot of the questions we get is, well, how do we integrate this into our clinics? Where is this technology best used? And this is sort of a decision tree that's been designed to kind of help navigate the clinician through the process. So a patient would come to the wound care center, and they would undergo, in terms of their intake, all the necessary intake vitals and updating of the medical records and things like that. But also the thought is that when a patient comes to see you, they'll also get a snapshot image. And that can be done in many different locations of the body, including the lower extremity, pressure ulcers, compromised surgical wounds. And then even further discussed, we can look at patients that are having hyperbaric oxygen treatments, looking at pre and post procedures to see if there is improvement in oxygenation. Qualify for the HBO. Do those patients actually qualify? Is there a way to create a marker for qualification? And then validate the effectiveness of these technologies. So when do we want to image a patient? Ideally, you want to image somebody sort of at the start of care. So sort of you first introduce a patient, you do your intake, your H&P, they have one of these existing wounds or some concerns of compromised circulation, then obtaining an image immediately is helpful. You can do that for pre and post debridements, pre and post advanced therapies, such as application of biologics. If there's somebody that has delay in wound care, you can go ahead and image them at that point, and then possibly post-operative to determine what's improved. And then tracking outcomes. That's ultimately kind of, I think, the big take home here is we want to be able to track outcomes and do a better job at the things that we are currently measuring. Some best practices guidelines is you want to identify patient to image daily prior to the clinic startup. So it's just help create a better flow of your clinic. Hold the device parallel to the imaging area, and there's guidelines on how to properly obtain image. You want to make sure you're obtaining serial images of the same region on the patient to be able to obtain accurate information. Variations in the way the pictures are obtained can change your overall outcomes. Image of the wound bed and peri-wound space. Again, you want to focus on the center. It has a sort of a dot that allows you to focus in, a laser dot allows you to focus in. And as they merge together, you obtain that image. Can imaging that peri-wound space to determine if there's any significance in increase in or decrease in oxygenation sort of on that peri-wound area. You want to include the most distal portion of the limb. The area of concern certainly is what's most important. And then want to re-image when clinically appropriate. And there's not a specific guideline set out for that quite yet. There's a bunch of different centers working with the technologies, and I've captured thousands of images. And so we're in the process of evaluating those images to sort of set the best standards of care for it. And you can see on the right, just kind of another diagram on how to best image these patients and where to image. And if you look at your diabetic foot, you want to image both on the dorsum, plantar surface, and then where there's a concern for a wound. On the leg wound, sort of similar. Ideally, you want to image the wound bed in that peri-wound space. If you have a pressure ulcer, again, you want to image the wound bed in that peri-wound space to get a determination of what the oxygenation looks like on that peri-wound area. And then at a wound dehiscence spot, generally, you want to focus on the wound bed. And it's not a bad idea also obtain an image of the peri-wound space, but the key is consistency. Every time you take those images, you want to remain consistent with obtaining those images to ensure the quality of images is the same as you move forward, so you can be able to better track those outcomes. And again, evidence-based medicine, since receiving FDA clearance and Health Canada clearance 2017, there's been a ton of information that's come out about this technology. We have 28 published articles, clinically based, and 23 peer-reviewed posters that have been out there. Most of y'all in the space of wound care likely have seen the technology, but may be somewhat unfamiliar with it. But there's a lot of great data out there thus far about applying the knowledge gained from the clinical trials to patient care outcomes to help promote consistency of treatment and optimal outcomes. And this body of work just continues to grow pretty much on a monthly basis as more and more people are working together. And as a team, we're all working together to help better standardize that care of the device, or standardize the treatment of the device, thus better being able to care for our patient population. And then reviewing and interpreting images, and this can sometimes be a bit challenging, and there is a bit of a learning curve. But the home screen is quite easy to navigate. There's been some updates here that I think actually make the technology improved and helps to better review and interpret your images. You can see here just kind of a grand overview of the picture you obtain, your little dots on that top kind of right-hand side of the picture that indicates the STO2 markers. You have line measurements now. We can either measure, again, from 12 to 6 in any kind of position you want to get adequate measurement against all that standardization. And you can do freehand measurement of the area. And so there's different tools and things that you can do to help measure the wound, to not only track progress of the size of the wound, but also help to track progress of oxygenation. Are things getting better, are things getting worse? And then what's even better is that you can now have these images where you can toggle back and forth between the color clinical image and the STO2 image, and then also create a side-by-side comparison, which is great. A lot of great software that comes along with this as well to help better interpret the images so you can kind of determine how things are progressing. And so from here, we'll jump into some clinical examples and applications of how you could best use this technology, where this may fit into your toolbox for care for your patients, and how can it help and assist for better quality outcomes. This is a quick slide here demonstrating the snapshot versus TCOMs. Some of the key images, or sorry, key advantages to the SnapshotNIR infrared is that there's no disposable cost, which is great. It's just a handheld, sort of like a mini computer that you're carrying around with you. It is a mini computer, but it's in a more handheld type situation. It takes significant time. It's pretty much an instantaneous event. When you capture the image, you get instantaneous feedback on your device, and that helps to allow you to interpret images faster. It also allows you to kind of move through your clinic a bit quicker. We all know that time is money, and certainly the more patients you can see, the better the outcomes for your clinics and the data there. It's non-contact, and many data points and kin images gives more insight into the wound when compared to TCOMs. And we know there's a lot of sort of disadvantages to the use of TCOM. The good news is there has been some preliminary evidence that shows that there's strong linear relationship found between the snapshot and TCOM values. So again, the idea is that these technologies currently aren't replacing what you're already doing. It's only going to augment what you're doing. But down the road, the thought is, well, maybe these types of technologies will replace some of these outdated technologies, and technologies that may take 30, 45 minutes, an hour to obtain, and are painful and not the most efficient for a flow pattern in a busy clinic. And again, this is a great sort of slide highlighting how Snapshot can be used for making surgical decisions. This is a patient who has a history of arterial disease, developed gangrene of the toe. You can see on the left-hand side, underwent a grade 2 amputation. Now, to the naked eye, you may not see much. There is slight necrosis along the incision line, but what you can't really see is on the right-hand side, when the snapshot image is obtained, that you have significant decrease in oxygenation, sort of around that whole area where the flap is. And this is captured about an hour after closure. And you see a little bit of hyperemia on the left-hand side on the color image, but on the right-hand side, the kin image shows flap may be at risk, while the clinical image pretty much appears normal. And so can this be avoided? And if this was obtained intraoperatively, would this change what you do? And some people may say, hey, why don't we pop some of these stitches and use alternative methods for closure? Maybe that's part of the reason why you have some decreased oxygenation at that area. Or do you need to have a further discussion with your vascular or interventionalist to better improve perfusion to the foot? And that same goes for the amputation picture on the right-hand side. You have an initial amputation demonstrated continued failure, which led to a secondary amputation. The whole idea is, if we have these tools and technologies with us early on, can we prevent secondary procedures? Can we sort of see things that we may not necessarily be able to predict intraoperatively? Of course, the picture on the top right is not immediately post-op. This is probably 1 to 2 weeks out, but you can see the necrosis here, and the picture below sort of demonstrates that, where you have that area of necrosis, you have significant decrease in oxygenation along that incision line. And again, it just kind of confirms that. But if we were to know this early on, this may help us to again, think outside the box and do alternative things to help get these patients to heal a bit quicker. Vascular interventions, this is a great tool to help determine both pre and post vascular intervention. Again, these are things that unless you're looking at an angiogram per se, you can't really realize the improvement. And in this particular slide, you have both the clinical picture, the pre-intervention procedure, where you see, the color scale gives you here sort of a red color at the toes, but sort of lightens up as it gets more proximal on the foot. And then the post-intervention, you see that nice red color, and that's what you want to see. That's an indicator of good oxygenation to the foot. Oxygen saturation is good, specifically on that lateral aspect of the foot. And so this is, again, a great tool for confirmatory purposes during vascular interventions and or post-vascular interventions if you want to capture these images with these patients, either intraoperatively and or at the bedside of the hospital or even in your clinics. Wound care, again, the whole idea with wound care is that maybe this technology can help improve debridement quality and procedure documentation. Here you can see both pre and post debridement. In the pre-debridement slide, see around the wound site, there is a decreased oxygenation at 21 and 27%. And then post debridement, now that oxygenation is up and improved at 64 and 60%. So this kind of, again, helps to confirm what you're doing is helping the wound, helping to improve oxygenation, and, so to kind of help guide some of the treatment modalities that may be necessary to get these patients into diabetic foot remission. And again, you see here the low StO2 in the periwound area and increased StO2 after debridement. Moving on with wound care, assessing and documentation wound healing with skin substitutes as the insurance companies kind of continue to dictate how we do our business. It's going to be more important to document sort of the progress for application of these skin substitutes. So how do we do that other than clinical evaluation? And sometimes that's subjective on who's looking at the wound site. So better technologies to help us do this are really important. And this is where I think Snapshot can really help us kind of really be a win for us. And here you see 1 week post application skin substitute, see kind of incorporation of skin substitute just at 1 week. You could see, even though with the naked eye it looks pretty good, but sometimes that's not good enough. Some people may describe this wound much differently. So if you have a confirmatory image, that's always helpful. And now you have 3 weeks post application. You can see how nicely oxygenated that foot is, that skin substitutes taking well. And this can be confirmatory for a lot of technologies and tools that we use to help get these wounds to heal, and also for advancement to biologics and skin substitutes. Again, good oxygenation spread throughout the substitute on the first slide, and on the second slide here, high StO2 throughout the entire wound area, which is what we want to see. Okay, we're moving on to additional ways that we can use these modalities in wound care. And again, this is used strictly in a confirmatory measure. We had done a study here at Baylor College of Medicine looking at E-stim, and there was a hypothesis that E-stim does help to improve not only wound healing, but also as a secondary finding, improve oxygenation to a wound. And here you can see here on the baseline, on the left-hand side, you had SaO2 at 71%. And then on the right-hand side, that StO2 is increased now to 83%. So this kind of just proves that, the device that we're using are improving wound beds. You have a 7.1% area reduction in the wound, and then a 12% increase in StO2. And again, these are just different ways that we can think to use these devices to help confirm sort of what we're looking at. And again, another great slide with the use of this E-stim device, looking at differentiation from baseline on the left-hand side, the 4-week follow-up. And not only do you see reduction in the wound site, which is good, but you also see increasing in the saturation, the StO2, from 79% to 85%. Again, confirmatory for the things that we're doing with these technologies. And then one more slide looking at a baseline, then at 15 minutes, 1 week, and 2 weeks. And you can see here, and this is really an interesting slide. This is sort of comparing the kit technology with other technologies out there. And what we were using originally was SPPs, and in the baseline you had an SPP of 52, and at the end, after 2 weeks, SPP of 74%. And this was, which is an increase in 30%. And this strongly correlated with the StO2. You had 77% on the baseline up to 85%. So there is a bit of correlation between these two technologies. And then again, this is just with utilization of standard of care. I won't get into the nitty gritty of the protocol of the paper, but basically standard of care wound care utilizing an E-stim device with pads placed above the malleoli for 15 minutes. daily. And so this just kind of goes to show, again, confirmatory that these types of technologies we're using to better patient outcomes are working. Again, debridement is also a great tool that you can use this device, see what tissue needs to be debrided and removed consistently. Here on the left-hand side, you have both pre and post-debridement, and then the right-hand side of post-debridement. And again, you just see sort of that increase in oxygenation of the area post-debridement, showing that, yes, you are removing some of that non-viable tissue, specifically at that most distal portion, more proximal portion of the wound site. You can see at the distal portion, which correlates with the color image, the sort of that blue-green area kind of towards the heel on the right-hand side. And that just shows that there is some necrotic tendon there, which would likely need additional debridement or modalities to help remove that to get full healing. And again, skin substitutes tracking progress, application that skin substitute at week 1, week 4, and then week 8. Just all confirmatory measures. I think that the more things that we do, the insurance companies are going to require a better confirmation of these technologies to ensure that what we're doing is helping to advance these patients towards healing. In hyperbarics is a really hot topic, and there's still not a lot of great clinical evidence that shows what it does specifically in the diabetic foot. There is a building body of evidence that's out there, but still, we can always do a better job at looking to define sort of what it is that we're looking at in both in the pre and post hyperbaric settings. Are we getting improvement? And this sort of is glaringly obvious. If you don't have to be a clinician to tell on the left hand side. There is a color difference, whether you understand the color changes or not. You can tell that on the left-hand side versus the right-hand side, there is significant color differentiation. Left-hand side, you see there's more blues and greens, red at the toes. On the right-hand side, now you have more yellows and reds and a lot less blue, which just shows that there's increase in oxygenation to the area. Again, defining and confirmatory that the hyperbaric oxygen therapy treatment for this particular individual is helping to improve oxygenation to a particular area. So what does this mean for outpatient and wound care centers? Serial debridement, medical necessity, tracking outcomes, the cellular tissue-based product applications. Is there adequate flow, adequate oxygenation in the wound bed to be an adequate recipient for these products? Is that product integrating well? What do those outcomes look like at various markers, generally 1 week, 2 weeks, 4 weeks? Can we use this in hyperbaric to help qualify patients for hyperbaric and document medical necessity? I think these are all important as clinical indicators are continuing to be difficult to obtain for these patients. And can we validate patient response to HBO and or outcomes? And then again, those advanced therapies, is it medically necessary to do certain things? What do those outcomes look like? And I think if we have other tools to do that, other than just, unfortunately, the clinical voice is just not enough these days to be able to confirm these types of things that we're doing, having technologies like this to kind of help guide us and assist us to go fight with the insurance companies, fight with the hospital systems to obtain the things that we need in order to get better outcomes is just all the better. And then reimbursement, I won't spend a lot of time on this, but just know that reimbursement is a very important part of this whole concept. We all know that integrating these technologies can be cumbersome at times, especially on the early phases. And once you kind of get that flow down, things do tend to get better. But there also is reimbursement codes that are out there for this. And those reimbursement codes are currently, as you see here, and they're consistently changing. Right now, the average payment is about $35, but there is some hope that those changes, that those reimbursement changes are ahead of us, and those reimbursement dollars may be significantly increased in the near future. And I'll kind of leave those conversations for those that do this best. I'm not here to discuss reimbursement. I'm here to give you my clinical perspective, but just know that there is already clinical codes to be able to bill for this. There is reimbursement that's being sought and paid out to providers, and certainly the company is acutely aware that these things need to continue to be at the forefront of sort of getting these products rolled out, and on the forefront of ensuring that reimbursement meets the need for the procedures. This includes a diagnostic code, reading the image. And so I think there's a lot of great things on the horizon that it will only make this technology much more enticing to utilize in your daily practice. And so again, this is kind of a quick overview. I think the best thing I could tell you is you got to get one of these things in your hands. I could tell you all day long, well, it's cool technology, it's great. Some of my benefits that I find with it is that it's very easy to tote around. You could put it in your backpack. I could take it from the clinic. I could take it over to the hospital. I could take it to the bedside. And I think all that's really helpful in order to create that continuity of care. This is an FDA 510K cleared, Health Canada approved device. Uses near-infrared spectroscopy to capture tissue oxyhemoglobin, deoxyhemoglobin, and total oxygenation saturation. It's completely portable, non-invasive, no injections, dyes, or patient contact, and immediate results with no disruption workflow. And I think that's really important to understand that this is not going to significantly slow down your clinic. It's something new to integrate into your clinics, but we could always discuss more ways to do that. I think every clinic has their own variation on how they're doing things and how they like to expedite their clinical process for their patients. It's all about that patient satisfaction. But again, if you have to spend an extra minute or two, I think patients, when they see these images and you have to have those conversations of debridements, amputations, revisions, I think to the layperson, it's a lot easier to have that conversation versus just saying, hey, your ABI is this, or your TBI is this, or your TCOM is this, we have to cut off your leg. And I think that's really hard for patients to understand. And so I think when it comes down to that patient satisfaction conversation, I know just in my own clinics that when patients see these images and we have this conversation, it just helps to ease that conversation to the layperson. And I think patients really enjoy it. And so again, thank you so much for your time today. There's a lot of information crammed in here. This is really exciting technology on the forefront. And I think technology will only help us to do a better job for our patients moving forward. Thank you for your time. If you have any questions, please feel free to reach out to the Kent Imaging Company and or myself, Brian Lepow. I can be found on the internet and on Twitter. Thank you very much for your time, and I hope you have a great day.